Well, hi guys, my name is Jessica White. I'm a senior here at the university. I'm majoring in psychology and I'm a pre-med student. Today I'm going to talk to you about the pain experience. What is pain? It's a universal human experience that we see every single day. But what do you really know about it? Thus far in medicine, we have found no biological markers present within the body that allows us to know exactly how much pain a person is in. Instead, when a person comes to the hospital complaining of a pain complaint, it's up to the physician to determine the answer to one question, in order to adequately treat that pain. What is the cause of pain? We have two models now that we use to answer this question, the biomedical model and the biopsychosocial model of pain. The biomedical model focuses more on the physical or the biological cause of the pain. The pain is due to the broken bone, it's due to the cut in the skin, it's due to the bulging disc in your back. Whereas this biopsychosocial model takes into account these emotional and mental and social aspects of your life, along with those physical aspects that might cause pain. The lack of sleep, the fact that your financial difficulties are having at the time, your anxiety level, the fact your boyfriend just broke up with you. It takes these things into account when determining what your cause of your pain is. So until recently, we only had this biomedical model to look at and evaluate pain. However, since the 20th century, this biopsychosocial model has been gaining support. Today I'm going to present you with 3 myths that people commonly have about pain. These myths are able to gain foothold because people are still looking at pain using this biomedical model. Learning the truth behind these myths will give you a new way to look at pain. So the first myth is the amount of tissue damage or abnormal vital signs are associated with the severity of a person's pain. First, let's look at vital signs. You would think somebody coming to you with this severe pain, their heart rate's going to be elevated, they're going to be breathing super fast, and their blood pressure is going to be through the roof. Research shows us that that is just not the case. For example, in one study done in an emergency department, they compared a person's vital signs, their heart rate, respiratory rate, and blood pressure, to a self-reported pain score that you give, scale from 1 to 10, 1 being, I don't really have a lot of pain, 10 being, this is the worst pain I've ever experienced in my life. All of these people present in this study had verifiable diagnoses that are associated with severe pain. Broken bones, kidney stones, these kinds of things. So these people are in pain. And yet this study showed that there was no relationship between these people's vital signs and their self-reported pain score. No relationship between them. Now in terms of the amount of tissue damage. So another study that was conducted, they took MRIs, which are just fancy x-rays, of people's lower backs, their lumbar spines. And all the people that were used in this study were completely asymptomatic. None of them were complaining of pain at all, and none of them had any history of previous back pain. The MRI showed that only 34% of these people had normal lumbar spines. The remaining percentage all had tissue damage in their lumbar spines, whether it was protruding or bulging discs. It looks pretty painful. These people had verifiable tissue damage and yet had no complaints of pain whatsoever. This shows us that this is also not a good predictor of the amount of pain that a person is in. The second myth, people exposed to the same pain stimulus will experience the same intensity of pain. That kind of makes sense, right? So here's the scenario. You grab a cookie sheet out of your oven without an oven mitt. That was foolish. All right, so the nerve endings in your skin that were exposed to the pain stimulus are going to transmit the message via all these little nerve fibers to your spinal cord and up into your brain. Your brain says, ow, I just grabbed a cookie sheet without an oven mitt. It registers pain. So in this example, now these nerves in your hand are really sensitive to things. If you think about it, you're no longer touching the cookie sheet, and yet your hand still hurts. Things that normally would cause you no pain whatsoever now hurt, like touching, snapping, writing something down. Any of these things cause you pain where they normally wouldn't. However, once the damaged tissue actually heals, this hypersensitivity goes back down to baseline. You can do all these things once again with absolutely no pain. However, Somebody exposed to a persistent pain stimulus, pain for a really long time. We typically see this in chronic pain patients. They actually have noticed modifications to their central nervous system. Central nervous system includes your brain and your spinal cord. Now, these documented modifications include an increased number of pain receptors into your spinal cord, as well as a decreased ability for your brain to inhibit the amount of pain that you experience. Now, these modifications persist even after the damaged tissue has been repaired. So it's safe to say that this person with these modifications to their central nervous system are going to experience pain differently than somebody without that. This is chronic pain. Okay, so this is myth number 3. The way you think about pain does not affect your pain whatsoever. To explain this myth, I'm going to briefly describe the gate control theory of pain. Now let's visualize the body's response to pain again. You've touched the hot cookie sheet, the skin with the nerve fibers in your skin that were exposed to the pain stimulus send the message to your spinal cord and then up into your brain. At the same time, however, the emotional and cognitive portions of your brain are sending descending signals back down toward the spinal cord to either amplify or dampen the amount of pain that you actually experience. It allows fewer or more of the pain signals to actually make it to your brain. Here's another way to think about it. You have an iPod and you plug it into a stereo system. You've got 2 volume knobs, one volume knob on your iPod and a volume knob on your stereo system. You can turn that volume all the way up on your iPod, and yet you can still control the volume level with the volume on the stereo system. Turn this all the way up, and you turn the volume knob all the way down on the stereo system, and you can barely hear the iPod. Now, if you turn the volume all the way up on the stereo system, it's really freaking loud, okay? So let's think about this in terms of the pain response. We're exposed to an extremely painful thing. We've turned the volume all the way up on our iPod. Now, if we think of our brain as that stereo knob, you can think of how you can dampen or amplify the amount of pain that you actually experience with positive thoughts and, I can get through this, it's not the worst thing in the world, it's going to get better. You turn down the volume knob, you experience less pain. Yet if you have a very negative outlook on pain, you turn up that volume knob and you actually tend to experience more pain with this same pain stimulus. All of this ties into the current research that I have been developing. As a psychology honors thesis that I'm conducting at DCH Regional Medical Center in the emergency department, I'm replicating the study I discussed earlier where they were comparing those vital signs, heart rate, respiratory rate, blood pressure, to that self-reported pain score from 1 to 10 that I talked about earlier. I anticipate that I will find absolutely no relationship between these 2 variables as previous research has shown. However, I'm expanding upon this with my research. Each participant is also given 3 questionnaires. These questionnaires are given to the participants before they receive any pain medication, and this allows us to get kind of a window into their mind of what they're thinking and feeling at the time of their pain. The first questionnaire measures the patient's catastrophizing level. Now, catastrophizing is a fancy way of saying how you think about pain. Somebody with a high catastrophizing level thinks extremely negatively about the pain experience. It is unbearable. It is horrible. It will never get any better. There is nothing I can do to reduce the intensity of the pain, so on and so forth. The second questionnaire is going to compare whether people view their pain in a sensory aspect, which is like the quality of pain. Is it throbbing? Is it shooting? Is it aching? Versus this affective view of pain, which is really focusing on the unpleasantness of pain. Does it cause me fear? Is it punishing? Is it cruel? The third questionnaire measures the anxiety level of the participant at that time. We then take these 3 variables and we compare it to the self-reported pain score from 1 to 10. I anticipate that we will find a relationship between these variables. People with high catastrophizing levels, high anxiety levels, are going to report a higher intensity of pain. In preliminary statistical testing, I was really excited to say that. Preliminary statistical testing has shown this to be true. Okay, so now what do we know about pain? Pain is subjective. It is different for everyone. Neither tissue pathology or abnormal vital signs are an adequate indicator of the amount of pain that somebody is in. Even people exposed to the same pain stimulus can experience pain differently. And the way you think about pain does affect your pain. And that's my TED Talk.